Now this graph illustrates the relationship between cardiac markers, that is markers of myocardial necrosis, with the components or the stages of the acute coronary syndrome. So acute coronary syndrome can be unstable angina. The next category is it can be non-STEMI, non-ST elevation myocardial infarction. And the third and most serious component of the acute coronary syndrome is STEMI, ST elevation myocardial infarction. So what changes would we expect to see with troponins in these conditions and with creatine kinase? Well, both of these are cardiac markers, and increased levels of them indicate myocardial necrosis. It indicates that some myocytes have died, presumably as a result of the infarction. Now, creatine kinase isn't used as commonly these days because creatine kinase can actually be released from any damaged muscle. If you want to be certain it's from the myocardium, you have to do a specific isoenzyme analysis. But it will rise with increasing myocardial damage. The more myocardial cells die, the more the creatine kinase will be raised. So the idea is with creatine kinase and troponins that they're not raised in unstable angina, because this is not associated with myocardial necrosis. It's a component of the acute coronary syndrome because it's caused by vascular occlusive pathology, but it's not associated with significant or really technically any myocardial necrosis. So the troponins are not raised in unstable angina. The patient can still have all the clinical features of acute coronary syndrome, but they won't have ST elevation, they won't have positive troponins. It's the troponin negative acute coronary syndrome. But then if there's a non-STEMI, then there's enough coronary thrombosis to cause myocardial infarction, and myocytes will start to die. And the more severe the condition, the higher the levels of troponin, the greater the mortality. So the higher the levels of troponin, the greater the levels of mortality that we can expect to unfortunately see in our patients. So the levels of troponin go up through increasing stages of severity in non-STEMI. But then we get even higher levels with STEMI. And of course in STEMI we're going to get the ST elevation as well, but increasing levels. And the greater the amount of myocardium that is infarcted, the higher the levels of troponin that we're going to see. So troponins are a very useful test. The cardiac specific troponins are troponins T or I. They are cardiospecific. And we would expect troponins to start rising probably about 3 hours after a myocardial infarction, 3 to 12 hours. It actually depends how sensitive your equipment is, wherever you're working, but we'd normally say they rise within 3 to 12 hours after MI. So if we can do baseline amounts of troponin straight away, then more troponins a few hours later, it's going to give us some indication of troponin increase. The peak levels are at 24 to 48 hours after an acute infarction, and then they slowly start to tail off after about 72 hours. They'll tail off slowly over a few days. And they're positively correlated with the amount of myocardial necrosis and mortality. Now physiologically what they do is they're associated with the actin myofilaments. You might remember that actin is the thin filament and myosin is the thick filament. And in relaxed muscle, the troponins actually work by preventing cross-bridging with the myosin microfilaments, thereby preventing contraction of the muscle. But during depolarization, there's increased levels of calcium, and the increased levels of intracellular calcium, the increased levels of calcium in the cell inhibit the troponins, allowing cross-bridging between the actin and the myosin, and therefore cardiac contraction. So if we think about the actin as being the thin filaments here, and the myosin as being the thicker filaments. It's the cross-bridging between these filaments that cause the contraction. So when the muscle contracts, cross-bridging draws the two together and the actin and myosin slide together. So the troponin is associated with the actin to prevent that happening inappropriately. And of course these are microfilaments, they're all inside myocytes. They're inside the cells, all these filaments. With their associated troponin associated with the actin thin filaments. So here's the troponins in here associated with the actin. And if this cell dies, the membrane will be disrupted and no longer able to contain the troponins inside the cell. So the troponins will leak out into the blood through the dead cell membrane, where we will detect them with our biochemical tests.